We've got quite a general one to start with, and that's around HRT.
Yeah.
So, first of all, is it okay to take HRT with PBC? And are there preferred options, for example, patches, tablets, gel? And I'll cut this one into a little mini as well, because it is quite a question that we do get asked quite a lot. So, if you want to.
Yes. Okay. So there are several aspects to it. So first up, is HRT safe to use in PBC? Yes, it is. Okay. In general terms, one or two caveats, not huge, but the concept that there is any problem with HRT is incorrect. It comes from the fact that sometimes female sex hormones can cause cholestasis, the sort of problem of poor bile flow that is part of PBC. And actually, you see that in cholestasis in pregnancy, you see it sometimes with the pill, you see it less commonly with HRT, but it does happen. That's got nothing to do with PBC. That is a drug reaction or a biological state in pregnancy. It looks like PBC, but it isn't PBC, and it's got nothing to do with it. And that's not more common or less common. That's not more common or less common in people with PBC. So that's where the idea that there might be a problem comes from. Mm-hmm. There are three reasons why you might want to have HRT. So the first is if you've had a hysterectomy with the ovaries taken out. So that's an absolute reason to do that, to go back to a sort of physiological state. So we'll kind of park that, because that's not how most people are thinking about it. So most people are thinking about it for one of two reasons. Historically, it was done to protect bones in women because of the risk of osteoporosis once people are postmenopausal. And I don't think we think that's a good idea anymore, largely because there are other very effective treatments for osteoporosis. So it can be part of the packages of benefits of HRT, but it's, I wouldn't use HRT purely for bone protection. There are simply better ways of doing that in 2025. So the other way is to reduce menopausal symptoms, impact on quality of life. And I think this is where the thinking has changed a lot. And I'm going to give a big mea culpa, which is that I don't think I, as a doctor, we as a clinic, used or thought about this enough. Okay. And we're obviously, as people know, very focused on symptoms and quality of life. And one of the concepts that we use is the pile of problems, if you like. So if somebody has brain fog or fatigue, there's very rarely a single cause for it. There are lots of things that can happen that all add up. Mm-hmm. And the important thing is that sometimes some of the things that are maybe lesser as a contribution are actually easier to treat. And although I don't think menopausal symptoms are worse in PBC or commoner in PBC, I think they add to the other problems of PBC, and they may be much easier to treat. And I think that's where me, myself, some of my colleagues may have been remiss, and we've all been Davina McCall about it, to be frank. And I think all credit to her for highlighting all of that. The other thing, of course, is that I work in my clinic. It's myself and a specialist nurse who people will know, Kath Houghton, who's a lovely, very experienced PBC nurse. And people talk to her about different things to the things they talk about with me. So what we've learned is that to have both of us there is useful, mm-hmm. because the conversations are different. And she tells me that those sorts of conversations are very common indeed. So I think there's it's what people feel comfortable talking about. So where am I in 2025? We talk about it a lot to people, about the potential for it to take away an element of the set of symptoms, not cure PBC fatigue, but it can make a big difference. And certainly we see that in practice. We tend not to prescribe it. It's not really my area of expertise. GPs are much more familiar with it. We do tend to recommend patches rather than tablets, for the simple reason that patches give you a low dose that goes straight into the circulation, whereas tablets give you a high dose, which then goes to the liver, where it gets partly broken down to give you a low dose in the circulation. So if there ever was going to be a problem with the liver, it would happen much more with tablets, because the liver gets the highest dose. So for that reason, which if we don't think there's a liver problem with it, is slightly illogical, I do accept that. But we tend to recommend patches, and people tend to use patches and tend to do very well with it. Is there a cancer risk associated with them? I think you've got to look at individual risks, and I think it comes into family histories and things like that. But not living the best life you can is a risk as well. So I think you can't in life get rid of all risks. You have to decide what's the right risk for you. I think the cancer risk is pretty low, but the GPs are very good advising about it. There is a risk of thrombosis. If you've had a deep vein thrombosis in the past, you need to be cautious about it. I can genuinely say, and all the people I know, who've been on HRT through the clinic, we have never seen a complication of HRT. So if these things happen, they don't happen frequently enough to happen in our patients. And we're, look after about 1,100 people, 90% of whom are women, the majority of whom are sort of peri and postmenopausal. So we would have seen things if they were common. So I think we underused it as part of the all-round package of improving life. We have no hesitations unless there's an obvious family risk factor, and we tend to use patches, probably for illogical reasons, but it's what we do, and it's what we recommend, and our experience is very good with them. So I do think it's something that is an important part of the all-round package. One of the things I do say that's very important is that in general, what we see is doctors who are not familiar with PBC regarding PBC as a reason to not do X, Y, and Z. And we could almost do a whole Q&A session on that. Is that the daft things that people have been told that you can't do because you've got PBC. And there's almost nothing that you can't take or do or whatever because you've got PBC. And, there are almost no drugs. I mean, literally no drugs that you can't take because you've got PBC. And so this is a classic example of that. And so you could say, well, HRT, what's it? If you were having a hip replacement, we wouldn't get involved in commenting on it. I just know that somebody who wants to go and talk to their GP about HRT, the GP will say, "Oh, I can't make that decision if you've got liver disease." So we tend to preempt that by saying that our view of HRT is as follows.
That's great, thank you. You mentioned Kath as well, your specialist nurse there. We get amazing feedback about specialist nurses at clinic. We'd love to see one at every clinic.
I think so.
Yeah,
I think so, and I think